Hello, in this video we will talk about 2023 updates on American Geriatric Society Beers Criteria highlights. My goal is to incorporate all those key points from this big criteria update so that you can apply to your patient care along with if you are preparing for USMLE exam, in-training exam, or board exam, you will be able to utilize all these key points. If you are new to this channel, welcome. My name is Dr. Farzana Hoque. I'm an associate professor of medicine. So let's jump right to it. This video will highlight all the important points from American Geriatric Society 2023 updated Beers criteria. So the question is, why we need to know Beers criteria? Because Beers criteria highlight all the potential inappropriate medication use in older adults. If you are a medical student, a resident physician, or already a board certified physician, you already know that polypharmacy is a hidden challenge for our geriatric population. And many times, truly, they are suffering from the complications or any side effects from the medications that healthcare professionals prescribe. So that's why knowing the Beers criteria update is very, very important so that we can potentially avoid all those inappropriate medication for our geriatric patients. Along with, we can simply know that, okay, what could be the side effect or interactions can happen. So to keep this video concise, I will only highlight all these strong recommendations. So if you are preparing for exam, remember that almost 99% of the time, they will focus on strong recommendations rather than moderate or weak. So this Beers criteria first focus on anticoagulation. According to these 2023 updates, DOAC, direct oral anticoagulation, was highly advised instead of warfarin for patients who are more than 65. Truly, they are advising to use DOAC rather than warfarin, unless there is contraindication for DOAC. Patients who are already on long-term users of warfarin or truly cannot afford DOAC or any other special circumstances, only that time warfarin can be used. But remember, truly it should be based on clinical judgment and need to make sure that, okay, patient is capable to monitor the INR regularly. So the teaching point will be for patients who are more than 65, DOAC is preferable rather than warfarin, unless there is different clinical indication or patient are on long-term warfarin and doing extremely well. So among the DOAC, Epi-7 or trade name Eliquis has a better safety profile in older patients. Xarelto or rivaroxaban was only advised if the patient need once daily dosing. Here, I would like to emphasize that I do not have any, nothing disclosure about any of these medications. This video is truly for educational purpose. So let's focus on aspirin. We know that previously aspirin was recommended for primary prevention, but right now, for primary prevention, these Beers criteria has changed their recommendation from use in caution to avoid initiating. According to the US Preventive Services Task Force recommendation. So the rule of thumb will be for primary prevention, aspirin is not recommended. So do not initiate aspirin for any geriatric patients for primary prevention. What about sulfonylurea? Straight point, avoid it. unless there is substantial barrier to using other effective medications. So if you are using sulfonylurea, always go with the short acting agents. But if you can avoid it, that's preferable, because we know that okay, side effect is very high, chance of hypoglycemia, weight gain. Those are not you know very easy to deal for our geriatric patients. What about pain medication? Avoid NSAIDs. I know that it's not always very easy to do. However, particularly when patients are on steroid or anticoagulations, make sure to avoid NSAIDs. Because during the time when the patients are on steroid, along with that, they are getting NSAIDs, the chance of GI issue is higher. In addition, when the patients are on anticoagulation, adding the NSAIDs can increase the chance of bleeding. What about baclofen? Baclofen should be avoided in older adults with renal insufficiency. So if the eGFR is less than 60, baclofen should be avoided, because baclofen increases the chance of encephalopathy. You may already have seen a couple of patients, particular geriatric patient, who come with encephalopathy, which is one of the common situation in any hospital. So particularly during that time, we need to be vigilant. We need to double check the medication, that whether the patient is on baclofen or not, and then we must stop it. If you have to use baclofen, please make sure to use lowest effective dose with close monitoring of mental status and definitely with renal function. I hope you find this video helpful. The goal was to highlight all the key points from Beers criteria so that you can use for your patient care as well as for your exam. If you want me to discuss any other updated guidelines or any other topic, please share in your comment. Please like this video, share with your friends, colleagues, and please subscribe to this channel. Until then, I wish you all the best and I look forward to seeing you in the next video. Take care.